Welcome. My name is Colleen Nelson. I am a program supervisor with Shining Care, and I'll be your moderator tonight for better words. So tonight, we've been asked to add some dementia into this. We have brought Maggie McNamara into our training tonight. So tonight is dementia and at-risk elders. If I can. Joanne, can you make there we go. Okay. So these are the topics which we can expect tonight. Dementia, delirium, psychosis, and depression, the basics to know. Compassionate communication, the do's and don'ts. Resources and programs available to help. Connecting with the right support system, which is our Gatekeeper program, and how to refer to that. And then 5, we have tips for dealing with death notification with sensitivity. So those are our topics for tonight. And first up is our speaker is Maggie McNamara. She is a family consultant and caregiver advocate with Passages Caregiver Resource Center. We've worked with Maggie for a very long time. She has an extremely large amount of experience in many areas of this. So we're really excited to have her tonight. And Maggie, thank you for joining us late this evening. So I'll hand that on over to you. Let me know when you need the slides to move forward.
Now would be good. Oh.
I'm going to move us over just a bit, I think. All right.
Okay. Thanks, Colleen. As she said, my name is Maggie McNamara, and I'm a family consultant, caregiver advocate for Passages Caregiver Resource Center. And we're an agency, a nonprofit, grant-funded agency. We've been around for nearly 40 years. We cover 10 counties, Shasta County, which is one of them. We cover all the way up to Modoc and all the way down to Plumas and Colusa. So we help family members who are taking care of a loved one. Typically, they have dementia, and I've been doing this for nearly 20 years. Before that, I worked in the Shasta Psychiatric Hospital, and I've done a lot of things, but this is all you need to know for tonight. Next slide, please. We'll talk about the definitions of each one of those, the causes and the risk factors. Next slide. And I just also want to say, everybody does confuse these terms, dementia and delirium. There is so much to tell you. Generally, I do this in a 4-week, 2-hour-a-week class. There's so much information. So I'm going to go through this very quickly and try to impart some of this information with you. And I hope that you find it helpful. And I hope if you have questions, please feel free to write them down and give them to Colleen or put them in the chat. Why is it significant to know the difference between dementia and delirium? And part of the reason is by 2030, old people, myself included, are going to double to 70 million. So this is a time bomb of morbidity, right? People are going to have a lot of illnesses, and we're also going to see a lot of dementia. Next slide, please. I'm sitting here clicking and nothing is happening.
Just one moment. Hang on.
Sure.
There you go.
So what is it? What's dementia? It's a condition of many diseases. It's not a disease itself. And it is used interchangeably with all the other causes, Alzheimer's disease, vascular dementia. We'll talk a little bit about each one of those. It's interchangeable. But if a doctor diagnoses someone with dementia, he's really not telling you a whole lot more than what symptoms the person may be presenting. Next slide. It is defined as impaired intellectual capacity with loss of memory, short-term memory, and loss of the ability to reason that affects a person's activities of daily living. And I think probably most of you know what they are, but I'll just briefly talk about them. Eating, dressing, bathing, toileting, transferring from a bed or a chair, and we include driving in this one as well. So in a nutshell, dementia is short-term memory loss with loss of some ability to reason that affects their daily living. There are other symptoms as well. We'll talk a little bit about them. Some of them depend on the cause. Next slide. Dementia is not a normal part of aging. I have so many people say, well, what do you expect at their age? Well, not this. You know, it means that something is happening within that person's brain. Next slide. And I just would like you to consider this. A lot of people are already predisposed to think of what somebody with dementia would look like. I'm not going to give you the answer, but I'd just like you to start thinking about this. What does someone with dementia look like? Could look like me. Probably doesn't look like Colleen, but it could. We just, we think people look fine, or we think somebody who doesn't look fine has it. Anyway, think about that. Next slide. So an estimated 6.2 million Americans who are 65 and older have Alzheimer's or some other related dementia. You'll start to see this a lot. AD for dementia, Alzheimer's disease, RD for related dementias. Go next slide. But that's a lot of people. Considering that 10,000 Americans turn 60 every day. So what are the primary causes of dementia? Most people know Alzheimer's and think Alzheimer's when they think of dementia, right? It is the most well-known, probably the most infamous. Probably they would say about 2/3 of people with dementia have Alzheimer's as the cause. And I'll just talk a little bit about what that cause is, what it looks like. Alzheimer's disease is plaques and tangles of toxic proteins, beta amyloid and tau protein, and they are consuming the inside and outside of brain cells. Alzheimer's disease, we first noticed, is short-term memory loss or getting lost in familiar places. That's why a lot of people think, uh-oh, I have Alzheimer's disease, when that may not be the case. It is slow and steady in its progression, and it will progress. There is no cure for this. And we're going to look at an Alzheimer's brain in a little bit. The next one of the primary causes is vascular dementia, and used to be called multi-infarct dementia, but typically it is if someone has had a stroke or has TIAs, which are transitory ischemic accidents, and or if they have heart disease where the arteries aren't getting enough blood to the brain, they're blocked. People with AFib can have dementia, and it's very different than Alzheimer's disease in that it does progress fairly slowly, but it's more of a stair step, plateaus and then down, and plateaus and then down. And people with vascular dementia keep their social skills longer and a lot of their abilities to make decisions longer. Lewy body disease is important to know because it was diagnosed as Alzheimer's for a long time, but big difference. So Lewy body disease, Dr. Lewy was around the same time as Dr. Alzheimer, and he found something else when he did autopsies on brains, these little bodies in people's brains that cause people to hallucinate. They do have short-term memory loss and loss of some ability to reason, but that fluctuates. It starts out maybe just a little bit, and then they'll have months where they're okay, and then it'll happen again. And then those time periods start getting closer together. But one of the important features of this is that people with Lewy body hallucinate, and they often hallucinate in miniature. So they may see a lot of ants, things like that, and maybe even children in their home. Many people with Lewy body disease know that they are hallucinating and the other people around them can't see them, but a lot of them don't. One of the precursors for Lewy body disease may be something called a REM sleep disorder. So somebody who doesn't have Lewy body, but they had REM sleep maybe 10 years ago or started 10 years ago, that can indicate that they're going to get Lewy body. And a REM sleep disorder means that they are sleeping in a deep sleep. And usually when we have REM sleep, right, that's our deep sleep. We don't move. You can tell somebody is in REM sleep because if you're watching them and you look at their eyelids, you can see under their eyelids that their eyes are moving. I don't know why you'd be watching them, but that's when you can see it anyway. Well, people with a REM sleep disorder will move and they will not be able to tell a difference between their dreams and reality. And it's dangerous for the caregiver because they can act things out. Also with Lewy body disease, people have a difficult time with balance or gait. It is considered a Parkinsonism. And it's important to know this because if you don't know that someone has dementia and they are hallucinating, you may believe that something else is happening. And so it's important to know this. Also, if people take medications that are for Alzheimer's disease, it can make their Lewy body worse. They are very, very sensitive to medications. Parkinson's disease, most of us know, can be tremor at rest. Not everybody has that, but they may have rigidity or masking where they are smiling, but you can't tell that they're smiling. And Parkinson's disease, 20% of people with that will get dementia from Parkinson's. Frontotemporal lobe is an important one to know. It doesn't start with short-term memory loss. It starts with personality change, mood change. So it can be mistaken for other illnesses, even mental illness. This part right here, your forehead, is your frontal lobe, and right here is your temporal lobe on either side. Your frontal lobe is where you have executive function, you make decisions and have ideas, and it is also your filter. So you don't say things that you are usually thinking. And so we'll see people who have this, we know that their frontal lobe is affected because they may say things like, oh my God, you shouldn't wear that bikini, you are too fat, you know, or just things that they would probably not ever say out loud. Oh, you went ahead. Okay, so that's fine. Anoxia, a loss of oxygen to the brain. People can look like they're fine, act like they're fine, but then get confused. They get lost. They are foggy. Go ahead, next slide. Head injury or traumatic brain injury is a cause. Normal pressure hydrocephalus, which is people call water on the brain, but it's really cerebrospinal fluid. That's how our brain talks to the rest of our body, from the brain through the spinal column. When people have normal pressure hydrocephalus, the ventricles get larger, the fluid starts making them larger because for some reason they're retaining that fluid. They can diagnose this through lumbar punctures. It is one that actually can be reversible, but if it's not caught in time, it won't be. Huntington's disease is hereditary. Some of you who know about Rolling Stone magazine may also know that Woody Guthrie, who wrote This Land Is Your Land, had Huntington's disease, and it ended very tragically. One of the things that happens is people with Huntington's disease need 5,000 to 7,000 calories a day. They are constantly, their muscles are constantly moving. So they're burning those calories. And so that's why they need them. They seem okay for a long period of time, maybe 10 years even. Everybody's going to be a little bit different. But then they start to become forgetful, have trouble walking, and can become violent and combative. That's actually one of the most devastating features of that disease. Alcohol-related dementias, if people drink massive quantities of alcohol, they can have the symptoms of dementia. If they stop drinking, it won't usually progress and get any worse unless they have another kind of dementia or something else happening. They'll get a little bump and seem better, and it's a good thing if they stop. But they also may have withdrawal symptoms that cause delirium. So we'll talk about that in a minute. Next slide, please. So what are some reversible dementias? Because there are, and nutritional deficiencies is one of them, often B12. And older people are subject to having poor nutrition for a lot of reasons. It could be cost, it could be eyesight, that they can't tell that the yogurt's gone bad in the refrigerator. Wow, okay, something happened. So can you go back? Oh, you went too far forward. I get it. I'm sorry, everybody. Let's say reactions to medications. Older people have a different way of metabolizing things. As a matter of fact, one of the most recent things that they've discovered is that if you give an older person Benadryl, where it has a half-life of, let's say 24 hours in somebody who's under 60, it may have a half-life of 3 days in a person who is elderly, so it can affect them longer. A lot of medications do that. A lot of medications are too harsh for people who are in their 80s or 90s. Emotional distress can look like dementia. I knew a 22-year-old young woman who lost her father, who became very depressed, and she had short-term memory loss. Now, she did not realize that she did at all, was not aware, but her coworkers and friends were able to tell her, you know, you can't remember anything for 5 minutes. She went into treatment, got antidepressants, and did some talk therapy, and that helped her. So that was reversed. But it's interesting to know that people so young can have that as well. So many older people are depressed and undiagnosed. So that's something that can, if it's diagnosed, can help them if they're having these symptoms. Metabolic disturbances like renal failure, liver failure, hypothyroidism can mimic dementia. And once that's corrected, they'll be okay. Vision and hearing problems. And I would like you to think about this, because if some of you may not be able to imagine this yet, but if you can't see very well and you're starting to have trouble hearing, you might start to isolate and withdraw. And those are things that they're actually risk factors for dementia, but, and hearing problems is also a risk factor for dementia. But a lot of people with these problems will quit saying, "What did you say? What did you say?" Because they get tired of saying that. And then they may start to think people are talking about them. They just don't participate anymore. So these are important to know, vision and hearing problems. Next slide, please. Oh, this is where we were. Okay, nutritional deficiencies, infections. And infections can show the same symptoms as dementia. Typically what we see is a urinary tract infection. Could be pneumonia, could be another kind of infection as well. Decubitus, or, you know, broken skin from lying down too long. We'll talk a little bit about this with delirium as well. Brain tumors, depending on where they're located, can look like dementia, and once they're removed, can be reversed. Next slide. So what are the risk factors for Alzheimer's disease? And this has not changed in almost 10 years. When somebody's 65 years of age or older, they have an 11% chance of developing the disease, okay? When they're around 85, there's a 50% chance about that they will get Alzheimer's or related dementia, but that also means that they have a 50% chance of not getting it, right? So another risk factor is a genetic predisposition. The most common one that we know of is called familial. It's early onset, it's genetic. And then there's late onset or sporadic, which is what we usually think of people over 65 or older. Next slide. Another risk factor, head trauma with loss of consciousness. So we see this a lot with football players. It's called chronic traumatic encephalopathy. Down syndrome is a risk factor. They aren't sure if it's exactly Alzheimer's that the person gets, but it's very much like Alzheimer's. And 30% of people with Down syndrome in their 50s will have, or already do have, Alzheimer's disease. And then 50% of people over the age of 60 will get Alzheimer's disease. Stroke activity in the brain is a risk factor. And the APOE4 allele, and these are genetic factors. There's 3 of these APOE4s. There's not 4 APOE alleles. One is APOE2, APOE3, and APOE4. APOE3, if you get the genetic test to see if you have these, seems to protect people against Alzheimer's. The APOE3 is a neutral, and the APOE4 is an allele for Alzheimer's disease. But just because you have it doesn't mean that you will get that. Next slide, please. So some more risk factors: sedentary lifestyle, high cholesterol, hypertension, diabetes. We all know these. We know that if it's not heart healthy, it's also not brain healthy, right? Next slide. Oh, so I wanted to show you a picture of a healthy brain. So this is what a healthy brain looks like. It's nice and pink, has these really tight lines that are called peaks and valleys, or sulci and gyri. Like I said, this brain is healthy. The person who gave it to us is not, because they're dead. Next slide, please. And this is an Alzheimer's disease brain. And I think that the difference between the two is really remarkable. As we age, everything seems to shrink. I'm an inch shorter than I was 10 years ago. Our brains also shrink, but not this drastically. This has atrophied because the toxic proteins have consumed the brain cells. So they get smaller, the brain gets smaller and smaller. And I usually show this to my caregivers so that when they ask me things like, why is he doing this? Why is he acting this way? Because his brain is not functioning properly, or her brain, or whoever brain it is. So remember this picture. If you get frustrated with somebody that you are treating who has dementia, it'll help you. Next slide. And that's just a cross section to give you an idea of the loss in an Alzheimer's brain. Next slide, please. So let's talk about the cognitive losses and changes that happen when somebody has, this is more probably specific to Alzheimer's in the beginning, but eventually everybody who have the different causes that we talked about, and those aren't the only causes, by the way, but those are the primary ones. Everybody will have these. Memory loss, short-term memory loss. This is a disease of memory loss. Loss of language. They may understand that they can't think of the word. They may be talking about their wristwatch and say their arm clock. They're trying to communicate, but people do lose the ability to communicate. They'll have a change in the experience of time. When a half hour has passed for us, maybe no time has passed for them. They lose the ability to think abstractly. They lose the ability to use good judgment. One example I had a caregiver who used to leave her husband at home a lot. She was much of a social butterfly and had things she wanted to do. And I asked her one time, are you still able to leave him home alone? And she's like, oh, sure, he's no problem. I'm not worried about him wandering or doing anything. I just tell him not to. She left one day and was playing bridge. And when she got home, her driveway had been asphalted. Her husband had written a check for $13,000. The check was already cashed. It was done. So she started staying home with him. Everything happens in our brains. Everything that happens to the rest of our body happens in our brains. So it makes sense in some ways that a person with dementia will have a change in visual perceptions. They just don't see things as the same as they used to. And shadows and different things may change what they think they see. If people wander, what some people do is to take a black rug, put it in front of the door. And if the person has had changes in their perception, they may think it's a hole in the ground and they won't leave. Next slide, please. Loss of orientation. It's one of the first signs of getting lost in familiar places. Social withdrawal for a lot of different reasons. Some people sense that there's something wrong. Some people know that there's something wrong. Some people just don't have the inclination to be around other people. They may have decreased inhibitions. That's because of their frontal lobe. And they usually do at some point have psychotic symptoms in the early stages of the disease. And I didn't tell you, but Alzheimer's disease can last for like 20 years. It usually is happening 10 years before it's ever diagnosed. So we'll see somebody that lasts around anywhere from 8 to 12 years. But they will very well may have psychotic symptoms later in the disease, and we'll talk about psychosis. I'll have a change in sleep. I didn't say anything about sundowners, but sundowners is a complication of dementia. They're not exactly sure of why it happens, but people who have sundowners right around sundown will start to become agitated and pace, and they may not sleep, and they may not sleep for long periods of time. This usually, everybody's different. Some people, this will last for a couple of days, some people for months. Sometimes it'll go away and then come back. There's a change in sense of time. I kind of talked about that. Change in expression of sexuality and intimacy. And I'll answer any questions about that, but I'm going to keep going here. Loss of personality. We are our memories. Our memories give us our personality. So we'll see changes in someone's personality. Next slide, please. Another functional losses, and I was talking about activities of daily living earlier. They won't be able to do them eventually. One of the first questions that I ask caregivers about their loved one with dementia are they able to feed themselves? Are they able to bathe themselves, make it to the bathroom? And a lot of the times people are able to do this for quite a period of time. Eventually, they won't be able to do any of those things. They'll have confusion and frustration with a task that's something they may have done all their life. Women who cook, or men for that matter, might not be able to follow a recipe anymore. They don't remember something they knew by heart. They worked on cars or did certain things, and they can't get from A to D anymore. That happens. It's very frustrating if they are aware of that. Loss of physical coordination. Everybody's different. So some people, it happens early on, and some people much later. The inability to handle finances or familiar activities. We talked a little bit about the fellow and the $13,000 check, but often one of the ways that we notice that people are having a difficult time, and maybe in the early stages of dementia, is they can't balance their checkbook, or they're writing checks over and over. They may put cash in an envelope to pay a bill, a lot of different things that we see. Next slide. Social losses. And once again, I want to say our memories make us who we are. Our memories give us our identity and our history. And as a person has memory loss, the way that this usually goes, short-term memory. So the newest memories that we have are the first to go. So we lose, last week first, and then we lose the year before that, and then the decade before that. That, of course, is oversimplified, but that's how it goes. And that's why people say, well, how come they can remember what they wore their first day of school, but they can't remember what they had for breakfast? Short-term memory loss. The newest memories go first, but eventually they lose their identity, they lose their history. They lose the ability to plan because they're living right now in this moment. They lose friends and their relationships as well. And when this is happening to the person with dementia, it's also happening to the caregiver. We see a lot of people who are good friends who quit coming around. And then the relationship, you're married to your wife. At some point, she doesn't seem like your wife anymore. I've had so many people tell me, this isn't my mom. This isn't the person I married, that kind of thing. One thing I will say about friends is that I live in a small town, and I have noticed that people in small towns seem to keep their friends for a longer period. Maybe not all of them, but they seem to stick around. Next slide, please. So they do retain some things, right? They can be more open emotionally. I've seen people who were mean and never hugged anybody and never had a good word to say. smile and hug people. That remember, their personalities can change. They often retain the ability to sing or dance. The part of their brain that has music is not affected the same way as the rest of the brain. So if you were trying to distract someone or maybe redirect them and you don't have any ice cream, you may just start singing a song that you think is from their time as a teenager, because those are the songs that they seem to react to the most. Other things retain. Pleasures are still pleasures. Eating good food, which usually becomes ice cream or cookies or cake. The sweets seem to appeal to a lot of people with dementia. They may still enjoy flowers. They may not be able to smell them, but they can see the colors. They love animals unless they had some problem with an animal in the past. They pet them, they talk to them, and they just seem to help a lot of people who have dementia. Next slide. They keep their sense of humor, but it's not the same kind of sense of humor as you say, you know, 3 firefighters walked into a bar, and then you go into the whole story. They would probably not understand that, but they do understand when someone trips and lands on their head. They understand a laugh track on a sitcom. And if other people are laughing, they will probably laugh as well. They can relate to cartoons where there's slapstick comedy. They retain their social graces. And why is this? Because remember, they keep their memories of their remote memories longer than short term. So what are some of the things we learn first? Say please, say thank you, and we get potty trained pretty early. So they try to remain continent. So what happens? The caregiver and the person with dementia learn to be together in the moment. And that's because the person with dementia is losing their past, you know, their recent past, their long-term past, and they don't have the ability to plan. So they are losing their future. So they live right now in this moment. Next slide, please. I'm wondering if I should go ahead to delirium first, and if we have a chance to come back to this. Were you guys able to come up with the compassionate communication to give out to them? If you did, advance it. If you didn't, I'll just talk.
Say that again, Maggie.
Are you able to give them the flyer on compassionate communication?
Right at this moment, no, but I can get that to them. Yes.
Okay, let's skip ahead to delirium. And if I have a chance, I'll go back to this.
Okay.
Okay, so delirium looks different than dementia, and the onset is more rapid. Remember, we talked about this earlier, Alzheimer's disease and some of the other ones are slow and steady, right? And so it happens over a longer period of time, where delirium can happen within 3 hours to a couple of days. You see fluctuation is very drastic. And it is, and I'll probably have a slide that says this, it is always medical. Next slide, please. So waxing and waning, decreasing and increasing symptoms over the course of the day. It is always medical. It is always abrupt. And if people aren't treated, the mortality rate of this is 22 to 76%. It's not always recognized. People just think, oh, they're old, they have dementia, but these are drastically different. They can be persistent in vulnerable populations. So that's our vulnerable population is the elderly. Once they've had delirium, it's real common to have it again. Next slide, please. So some of the causes of delirium: infections, urinary tract infection, pneumonia, and decubitus can cause the infections. And once those are cleared up, you'll see the delirium cease and desist. And people are different, right? As we are unique When we don't have dementia or delirium, we are unique when we have it. So some of the symptoms are common. That's how we know what's happening, but they happen differently within all people. Mad cow disease is a cause of delirium. Kidney disease, because when your organs aren't functioning, the rest of you doesn't function as well. Sepsis, substance and alcohol withdrawal can contribute to cases or causes of delirium. So we hope that when people have to do that or do that, they are able to be under the care of a professional. Dehydration, I want to talk about that in a second. Medication reaction and interaction. I said earlier, people that are elderly metabolize things differently. And we see a lot of delirium because of medications. Dehydration I wanted to talk to you about. I had a personal experience recently. My mom was in a rehab hospital and they offered her water. And if the patient says no, then they can't give them the water. She became dehydrated. I saw the delirium starting. And by the time they took her to the acute care hospital. By the time they got her there, she was swearing. And it's not that my mom never swore, but she didn't say the things that she was saying. They got her upstairs, tried to give her medication to calm her down. And she essentially was acting like a 2-year-old having a tantrum. They gave her a pill. She spat it out across the room. And if she knew what was happening with her, she would have been mortified. But they did hydrate her and she was okay by the next day. Next slide, please. Another risk factors, people who are hospitalized and are in the hospital for a long time, it is a risk factor for them. They become delirious. If they have multiple morbidities or medical issues, it's a risk factor. Multiple medications like we talked about. If they have a terminal illness, you can see that there may be a point where they are delirious and that can usually be treated. Sensory deprivation, and I'm really not even clear on what I would tell you that is. Sleep deprivation. I think most of us in the jobs that we have or have had, if you are awake for 3 days, you know that you do not function well, might see things, hear things, and a lot of coffee doesn't help. Next slide, please. So this is a mnemonic if they spell delirium incorrectly, but if you want to remember it, it might help you understand if somebody is having delirium when you see them, an interaction of drugs, problems with the endocrine system, so the hormones, epilepsy, people who are having seizures, they may present as delirious before and during each before each seizure, lung disease, infections again, injuries, some of the things that we've already talked about. So next slide, please. So how do you treat delirium? Well, you have to address the underlying medical issue. If you don't know anything about the person, that may be difficult. But some of the things like dehydration, urinary tract infection, I have a P chart that I actually got from my local volunteer fire company. My brother was the assistant chief for a long time. And he brought me home this chart that had, and it was from CAL FIRE, wonderful colors of P. So you can kind of tell if there's urine involved, if they have a urinary tract infection. Next slide. How do you work with someone who has these problems? Well, you want to provide support and orientation if possible. And it may not be possible if they're in the deep throes of delirium. It may take some time. One of the things that I know about first responders, EMTs, firefighters, is that they are calm, they are professional, and they are able to keep everybody in the room calm as well. This is one of the most important things that anybody can do with dementia or with delirium or with psychosis and even with depression, to be reassuring, right? To stay calm and be really sincere, because if you are not sincere in anything that you're saying, a person with delirium or dementia, they'll know it. Try to keep stimulation to a minimum, right? If you can lower the lights and keep things calm. And ambulate the patient or get them up every now and again. Next slide, please. So this is where we're going to go really quickly. We're going to talk a little bit about each one of these: dementia, delirium, psychosis, depression. We'll do it pretty quickly. Go next slide. So dementia, we've talked about its memory impairment, right? They cannot remember who you are, who they are, how to do things eventually. They're disoriented in place and time. And dementia is chronic, has a slow onset, and it's progressive. There's no cure. Next slide. Delirium is really rapid onset, right? And it's fluctuating levels of consciousness. They have a difficult time keeping focusing and keeping attention on something. They're disoriented. They may have visual hallucinations. Often and usually they are very agitated, and they do have some of the symptoms of dementia. But remember, this happens really quickly, and it is a medical condition that's reversed once that condition is treated. Next slide, please. So psychotic disorders, I'm not going to go into it too very much. People with dementia often have psychotic disorders. People with delirium, yes. Their realities have changed. Their realities are totally different than what we are experiencing. But it still looks a little bit different, right? And they're usually, for psychotic disorders without dementia or without delirium, there are, well, it says right here, slow onset with a prodromal syndrome. It just means that there are signs that come on slowly before the major psychotic disorder. This can indicate, depression with psychotic features, which we're going to see more in the elderly, or schizophrenia, which we can see late onset, but often it happens with, like I said, dementia, delusions, things like that, and can be treated with antipsychotics medication. Next slide, please. And depression. Well, we have here, it says sadness and loss of interest and pleasure, which is really a very salient feature of depression. But I would also say people who are depressed can present with anger and be combative. So you want to be careful around people who have depression and are exhibiting those symptoms. They often have problems with sleep. They're either sleeping too much, or I've known people who have been awake for like 10 days straight. And it's really hard to watch that happen with someone. Might eat too much or eat too little, can't concentrate, have low energy. Their self-esteem is, gone. They feel worthless, helpless, and they often have suicidal ideation. They may not have intent, but the thoughts are there, and you can never take that lightly. It may happen once, or it can happen a lot. Next slide, please. Okay. So usually I say, thank you for what you do. But these are just some of the sources that I used for some of that information. Any questions?
Okay.
Okay, so I would say if there's any questions, if we could pop them into the chat, unless Bob, you want to relay any questions that you might have from your group there.
Yes, we have one question.
Okay.
Maybe you mentioned that being socially withdrawn was a early sign of dementia. And my question is that a symptom of, or do people who are withdrawn become later dementia because they're at risk?
Good question. So it is a symptom of the dementia. But I would also say, now, you know what? So that's a double-edged sword here. We see it as a symptom when people have dementia. They can become withdrawn. We're not always clear on the reason. Some people are aware that there's something going wrong and they feel uncomfortable around other people. But I don't know that I would say withdrawal, but isolation can contribute to dementia. So there's a difference. Does that make sense to you?
Yes.
Yeah, isolation is a dangerous component for elderly people on their own. And honestly, people who may not even have dementia may become psychotic when they're isolating, become fearful, a little paranoid.
Thank you.
Okay. Was that clear?
Yep, very good. Thank you.
Okay, thanks.
Right on.
All right. Well, thank you, Megan. I always learn something from you when you speak for us. So I appreciate your expertise there.
Well, remember, don't freeze lettuce.
Yes, Maggie.
Okay.
Maggie's one of those that we never sit too close during a meeting. She'll get us in trouble with her humor. All right. So next we were going to bring Joanne back on. Joanne is our executive director and founder of Shining Care. She is also our certified care manager and has her degree in social work. She has been doing it over 25 years. She has experience with her own family, caring for them through care management and just being the daughter having to care for her. So she's going to go over some resources and programs that are available to help. So we'll have Joanne, you're up.
Okay. You know, it's so weird. I have so much experience, but I'm only 29. So I don't know how that's, but so yes, I'm the founder and director of Shining Care, and we're just so glad to be bringing this information to you. Maggie is fantastic, isn't she? We do so many referrals to Passages Caregiver Resource Center, where it connects them to Maggie and her support groups and her information and respite. So we want to thank, and Passages is a sponsor to this quarter's educational campaigns. We want to give a shout out to them. We are a small but mighty nonprofit organization with just a real passion to help our at-risk elders and their loved ones. I know that all of you know there's a huge need for more support and assistance. So we're just doing everything that we can. Next slide. So Colleen's going to be talking to you about our Gatekeeper program, and we're just thrilled to know that your community is, and all of you who are in your fields in firefighting and EMT are open to becoming gatekeepers, and she's going to talk about that. But real quick, I just wanted to share that we are a free resource, and the resource is available to the greater Boerne area. And so all of the things that Maggie talked about, our Aging Life Care program addresses. And, you know, Maggie was talking about isolation, and we've seen it firsthand over and over, how isolation is so detrimental to, you know, our elders. And a big part of what we do is to help people get reconnected to what we call a circle of support. And that's a combination of services that they're eligible for and, you know, friends, family, neighbors, natural supports, and try to get that person back to being connected. And unfortunately, you know, so many people have dementia and they're at some phase in the dementia. And as we learned with Maggie tonight, the dementia really does often cause isolation. So we're here to help. So when we get a referral, we are able to do a free comprehensive needs assessment. And that includes an assessment for cognition to see how they're doing. We do free memory screenings. And basically we can, you know, with those memory screenings and the cognitive assessments that we do, we can help people get connected to the assistance they need for those treatable dementias that we learned about tonight. And then, you know, if they happen to have a type of dementia that's not treatable, then we can help the person and the family come up with a plan to get them the right kind of assistance and support that they need. we don't wear Superman capes. We can't do everything. But over the last, 30 years, we've been successful in coming up with a plan to help people do better. So we're excited to bring that to Bernie. We also have our crisis response and assistance program. And yes, after we officially named it that, we realized that the acronym is CRAP. So you might hear us say the CRAP program. Sorry, we kept it. We figured it's fitting. If there's a crisis or a disaster, it fits. So basically, that's outreach and assistance to at-risk elders and their family caregivers in times of crisis. So with COVID, of course, when there was that shutdown in the beginning, and our already semi-isolated seniors were feeling very isolated, we were able to do phone calls where we did basically an extensive interview to determine really how they're doing, because most of our elders, they're proud, and they should be. They've lived a long life and they don't want to burden people, and it's embarrassing to think that they might need some help. So most of the time they'll tell their loved ones and their friends, I'm fine, I've got this under control. So when we do our outreach calls in times of crisis, it's very friendly, it's very casual, but it's on our end, it's very detailed. And we gather a lot of information, and 9 times out of 10, that person that said that they're all set. So for example, a fire situation, yes, I'm ready. After we go through our interview, we've discovered they're absolutely not ready. They're not prepared. There's not a plan. And so then with that information, then we can help them come up with a plan to make sure that they're safe. So that's our crisis response and assistance program. Colleen's going to talk about our gatekeeper program. And of course, we do have a lot of educational information out there. Our website, I'll be talking about that later, full of helpful articles. I always say you don't know what you don't know. Most families have good intentions, but it's overwhelming. They're not sure what to do. So today we were up in Bernie. We did a goodie bag giveaway with lots of helpful information and resources, so people know their resources. Of course, we have our website. We do webinars like tonight. We have a symposium coming up and things like that. And then we have our friendly televisitor program, which we've just launched officially. So we're looking for volunteers. We have a small handful of volunteers that can do friendly visit phone calls. And when COVID is done, hopefully someday soon, then they can go and do home visits that are just very casual, but our friendly visitors are trained. So they're trained to do a mini assessment to make sure that that person is okay, that there hasn't been a change in condition or circumstances, and they can bring that information back to our care managers, and then we can come in and do an intervention to make sure they're okay. So remember Shining Care. It is challenging for us to get up into the Bernie area frequently in person. But one thing that COVID has taught us is that we really are able to help people virtually and by phone quite a bit. So, we just want to get the word out that we're a resource, and our job is not to do everything. So with our aging life care program, once we assess everything that might be putting the person at risk, that might be causing a loss in quality of life, not quality of life, we don't want that, quality of life, then we come up with a plan with the person and with the family, incorporating that circle of support to make sure they're okay. So I think that's it for now. Colleen?
Was there any questions before we move on?
No, we're good here.
Okay. Well, I've introduced myself as Colleen Nelson, program supervisor. I started out with Shining Care when we first got the contract for the Gatekeeper program. It was initially through Shasta County Health and Human Services Agency through the Adult Service Program. it is an amazing program. It is used nationwide. It is actually universal, but basically it equips and mobilizes the community to recognize when an older adult's safety and well-being are at risk, and to reach out for support and connection to free assistance so you can preserve their safety, health, and dignity at the highest level of independence and quality of life. That's the gist of it. But it was actually developed in 1978. And the whole idea behind it was there was a demographic of older adults that don't reach out and ask for help. Even if you send it in the mail, the radio, the newspaper, doesn't matter. They are unable to reach out and connect to that help. So they thought, well, if we train all non-traditional, whether it's the bank teller, whether it's the favorite waitress, you're looking at non-traditional, I'm training them how to recognize those signs and then get them to connect them to the program so they can get help. The idea of that is they already have that favorite teller or that favorite waitress or, the guy at the grocery store. They already have that relationship. So it's easier for them to say, you know what, I have some friends that are able to help you. Let's call them together. They're more likely to going to accept that help than saying, oh, here, this is number. They might be able to help you. We don't want that. We want to be able to engage with them and get them the help they have. So what we'll be discussing briefly, because I really want to get to the last section, and that was the serving about the death notices. So a lot of this you will already know, but I do want to go over it with you. So as we know that Shasta County has a large growing number of elders whose safety and well-being are at risk. Without that intervention, as you know, the following critical situations exist. So the loss of health and independence, premature institutionalization, hospitalization, and readmissions. We see a lot of that. Elder abuse and neglect. And it was amazing through COVID how much we saw of that, whether it was physical, financial, emotional, sexual abuse. It's all there, and it's sad. So it's really important with the Gatekeeper program, the more agencies, businesses, and social community groups that are trained to this in your community, the more eyes and ears we have out there for older adults and can catch things before it gets into a situation that is beyond a lot of help and the damage is done. So it is important to know when and how to connect these older adults to the needed assistance. And as we all know, as we age, our conditions change, and it does cause them to be unable to do those activities of daily living, as Maggie had mentioned earlier. And that can cause that isolation. And it could be as simple as a hearing aid being chewed up by their pet. It's too expensive to get those replaced. And as Maggie said, they get frustrated because their friends they're not being able to communicate with them. And all they're doing is reading their features and their body language. And they figure I can't do it. So they're back at home and they're isolated. And guess who's becoming their new friend? It's those people calling on, phones, or it's scams in the mail, something else that keeps them busy. And there goes that financial abuse. So they often don't recognize when there's been a change. And if they do, they may feel uncertain of how to reach out for help. So again, that trusted gatekeeper is so important to get them connected, and anyone can be a gatekeeper. So I encourage you in Fernie and all the areas up there to encourage folks to become trained. It's free. I can, curtail that to meet their need of time that they have for us to present for them. The signs that we train people on are what you'll see here is the mental state. Maggie has gone through a lot of this, so I'll just mention them briefly. Mental state confusion, disorientation, memory loss. Physical, difficulty seeing, hearing, walking, alcohol abuse, substance abuse. Emotional, the loss of a loved one, a pet, a spouse, a friend. They get withdrawn and appetite changes. They don't take care of themselves. And Joanne always says it's a slippery slope. And it really is. It goes really quick with those older adults. Social, being isolated. And we have programs like Joanne mentioned today, or a friendly visitor through the telephone, the televisitor. There's also Well Connected. It is a catalog of different classes from philosophy to music to armchair traveling that is free, and it can be done over the phone, and it's facilitated or even on a computer if they have that capability. So there's other ways for social activities. We just need to keep them engaged. Personal appearance, it could be, their normal days sweats and a t-shirt, but if you're starting to smell body odors, you're seeing weight loss or you're seeing food stains, that they're really being uncut. That's also, a sign of them being at risk. Environment, you're seeing the home to start to deteriorate. We've had a call where a woman had all these cats in her house and couldn't pay her power bill. So the power got shut off. She would sleep by the front door. The cats had taken over the house, and her bedroom now had become basically a litter box. Economic, having trouble regarding money matters. So do they pay their power bill or do they pay for their medication? We know that the cost of food is going up. The cost of medication is going up. It's getting harder and harder for them to have to figure that out. And then being a victim of fraud. We have a case now that hundreds of thousands of dollars are being scammed out of this woman. And it's a really tough case. So seeing these is heartbreaking. But if we have a community that is trained to look for these, being those extra eyes and ears in the community and being able to connect them to us so we can get them connected to the help they need. Keep them healthy, safe, and independent as long as possible. Because, our elders are a big part of our economy as well. So how do you connect them? We always say the best thing to do is to call in the moment. And I know with first responders, that can be kind of a tough thing. With our Reading Fire Department, we're having referral cards made, which we can get out to Bernie, and you can, give them the referral card. But the fire department, we ask them also to call us with the name, their address, their phone number, and their age and what the concern is. But we do have to have consent. This program is consensual. Otherwise, we know that's not going to work if we don't have consent. We can lead them to the water, but they're not going to drink. If it's not possible, like I said, have them reach out to us. We'll get you a card or brochures for right now. But we do need the permission, and then we can follow up. So just let them know that I'll go ahead and call them and let them know. They'll give you a call and we'll take it from there. So as Joanne mentioned earlier, once they've been referred to us with consent, then we'll reach out for a free consultation and assessment. And as you'll see here, you'll see a risk and needs assessment. That included your memory screening, connection to community services and specialists, care planning and age care solutions, connection to in-home care and other helpful programs and services. We work with so many different agencies. We know them by name. We could have a really tough case that maybe the personalities, you got a kind of a person that's a little bit on the crotchety side. One agency really doesn't have the staffing to really take care of that person, because you don't want to send someone in that is afraid of that client. So connecting us with and allowing us to help them get connected to the right services and the right agencies. And then reconnection to natural support, such as family, friends, and neighbors, is so important. You consider them that hub of a wheel, plugging in home health, home care, all different programs.
Colleen, we have a question for you.
Okay.
You mentioned elderly, and my question to you is, elderly an age or is elderly a condition?
I can't quite hear too well, Bob. Can you speak up a little bit?
Is elderly an age issue or a condition issue?
So when we say elders, it's an older adult, and typically it's 60 and above, which I think is very young. But and by the way, we serve people who are 18 years of age and older. Our emphasis is on older adults. But if you have a case that you see is falling between the cracks, maybe they have any of the things that Maggie was talking about, for example, you can make that referral to us. Our funding, we have partial funding through Shasta County Health and Human Services. Our funding is limited, so that's one of our challenges, but we do the best we can. Our mission, our vision is to help these folks who are falling between the cracks. So when in doubt, please go ahead and make the referral and we'll just do the very best that we can. So I hope I answered your question. So when we say elders, we're talking 60 and above, but we have successfully helped adults who are younger.
Okay.
Yeah.
Perfect, thanks.
And then, we always encourage everyone to make those reports to Adult Protective Services. We know a lot of folks get frustrated because they don't feel like anything's getting done, but the constant reporting helps build the cases for, future solutions. I am going to go ahead and hand this back over to Joanne so we can go over the tips dealing with death notifications with sensitivity. We were blessed that Betty Harrison Smith, she was a Reading Police Department chaplain. She is now retired, but she sits on a couple of boards with us, and we reached out to her to provide this information. So I'm going to go ahead and allow Joanne to pop back on, and we have these last two slides.
Right. And I do know that it is 8:06, and we can get you this information. I don't know if you need to leave now. We can stay on the webinar and I can go through this, and we are recording this. So how are you doing, Bob? Do you want us to continue?
Yeah, you're fine.
Okay.
Molly and I are still awake. We haven't done it all.
Okay. All right. So
It's good.
okay. And so, I always say, because we deal with crisis quite a bit, and death is one of the things. We don't have to usually do a notification. So we really, our hearts go out to you all that have to do this very sensitive thing. But like Maggie even mentioned, I think, the first step is, just being aware of our own emotions and kind of getting that. And I know that you all are good at this, but and some certain situations will trigger us. So for example, if you have a dear family member and this particular situation where you have to go give a notice matches your situation, it's called transference, that can be harder. And so to just have that recognition of how are you doing emotionally, and asking for help when it's one of those situations, if it's possible, that it's just too close to home for you. But it's okay to be genuine and just say, we never want to sympathize. And it's kind of like a pity thing, but we want to empathize and let people know that we feel them, we understand, we have an understanding, we have a situation that we can relate to them about. And I personally think it's okay to say, I'm feeling you right now, and this is hard for me too. And then you follow these things. We don't ever want to make it about us, of course, never we want to make it about us, but when it's the large elephant in the room and if for some reason you happen to start crying or something, it's okay to say, I apologize, I'm fine, I'm just really, I can relate to what's happening to you, and then you move on. So I'm going to stick to this agenda. So always make notifications in person, never by telephone. If the survivor is far away, contact the medical examiner or law enforcement personnel where the survivor lives. Make notifications as soon as possible, but be sure of the identity of the victim first. Make notifications in pairs if that's at all possible. One person can do the talking and the other person can be a backup, as survivors may experience some severe emotional reactions. If possible, a male-female team is the best. Notify everyone who is present in the household. Take separate vehicles if possible. One notifier can remain to wait for family, friends to be with the survivor. One notifier can remain behind to help notifications to the rest of the family. Those making the notification should first identify themselves. If you have credentials, show them, and ask to come inside if you can. Do not make notification at the front door. if you can help the survivor, make sure they're inside and seated. Next slide. Make sure that the notification is made to the proper person, not just anyone in the house. Make sure that you know the relationship of the survivor to the victim, if you can know that at all. Tell the survivor what happened and the result. Use a simple and direct explanation. And some examples here. I have some bad news to tell you. Your son was involved in a car accident today and was killed. Your husband was shot today and he died. Your father had a heart attack at work and he died. Just keeping it simple and direct. Avoid vague phrases like your son passed away or your son was lost, which I think we all have a tendency to want to do to kind of soften things. It is better to be direct. Give the survivor all the news that you have. Always refer to the victim by name. Of course, never refer to the person as the body. Always say, I am sorry for your loss. Don't say, I understand your feelings, because you really don't. So I know I just said something different, but hopefully I've made the distinction. So, I can understand how you may be feeling. I can, and empathizing. So with my crisis intervention training, when you have someone in crisis and they may react in so many different ways, that may be anger, it may be hysterical crying. When we give an empathetic response, like I can see, how much you're upset. I hear you saying this. It's that active listening. It's that empathy. It helps them move through that severe emotional response so you can get to this communication that we're talking about. Because if you have a person that's in a severe emotional crisis and they're hysterical, we can't, start talking it over that. We have to work through that. So I have more information on crisis intervention. I'd be happy to share that with you. Okay. I think what this bullet point is talking about is when, I know how you feel. Well, we don't know how the person feels because we're not in their shoes. So it's a fine line. It's a fine distinction. Ask the survivor who they should call, family, friends, neighbors. Offer to be there as they make the calls. Suggest they call a family member or neighbor to be with them. If you can, offer to stay with the survivor until someone arrives. Be flexible. Survivors react to death differently, from no reaction at all at first to severe emotion, physical illness, or anger, like I talked about. Of course, never appear to be judgmental in any way, either about the victim or the survivor. You are there to deliver the news, just the facts. Do you all have chaplain? Do you have any chaplains up there?
Yeah, we do. We have a couple from our local church.
Okay.
Henry is probably the bigger one that comes out all the time. But we use them frequently. When people want them, we call them out. So.
Okay, great. That's good. I mean, because they're the ones that are really, obviously have all the training and all of that to do this. But so hopefully that was helpful. If you're feeling like you need more information on that, we would be happy to do our best to get more for you.
Okay.
We just have a quick video that we've heard from a lot of people that it really just helped them understand, our resources and what we do. So we'll play that real quick.
You have to You have to share your sound on Zoom when you're doing a video. If it's got sound, you have to share the sound too.
Just go over the potential of probably selling his home here in Reading. He would make comments about being lonely and wanting to be able to get out of the home he was in and be able to go grocery shopping or be able to go out and get something to eat. So quite often we would go to Chinese restaurants that happened to be his favorite.
And the main reason he likes it is because he puts a bunch of like salt and seasoning and everything on his food, and this is the perfect place to do it because it didn't have a lot of taste in the food.
He had this little dog that my son Luca would play with every time he would go over there. Jerry kind of took a role as a client at first, but then that morphed into oh, he loves my kids and wants to get my son things. So it turned more into a secondary like grandfather position for my kids and also somewhat for me.
When I tell people about Shining Care, I always tell them they're small, but they are mighty. I've seen them shine just when you have elders who call in, and oftentimes they're alone. They have no support system. They have no one to rely on. By the end of the conversation, whether it takes 5 minutes, a half an hour, that person feels like they have hope.
I would visit Jerry quite often. I hadn't heard from him, and so I went to check on him, and I knocked on the door, and I could hear he was in there, but his voice didn't sound right. So I said, Jerry, are you okay? Can you come unlock the door? And he said, no, I can't get to the door. And so I said, okay, I'll go to the front and get a key. It was a mess. And so the woman who worked at the facility closed the door and said, oh, okay, you're sick. I said, what do we do now? And she goes, well, it's not assisted living. It's, he's independent living. And so I called Marty with Shining Care and I said, Marty, what are we supposed to do? I mean, this is not okay. Something's wrong. She said, tell him to call 911.
The Gatekeeper program is set up so that you can train others in our community to look for signs for at-risk seniors. It not only empowers you in your place of employment, but in your own personal life. Not only are they helping them with their day-to-day needs, but looking at people as their grandmother or their grandfather, or maybe their aunt or their uncle, someone that they can rely on.
Marty kept me posted when he was in the hospital, and then he got out. And throughout the whole process, when I would go in to see Jerry, my job at that point in my mind was not to be there as a real estate agent. It was to be there as a friend. It's heartwarming to know that you can open yourself up and forget about really work and your work role and get more into connections with humans and, make sure that towards the end of their life, they are, in a good place too and not alone.
So it made me sad because I would think there are other people like him out there and they don't have people to help them. And if they don't have people to help them, how are they gonna do the stuff that they want to do by the time they're old and they don't have a lot of time left?
The elders in our community, these are our moms and our dads, our aunts and our uncles. And we are honored to be able to give back to them, to provide them that comfort in a safe environment that they would need as they move on to the next phase in their life. We hope that you will join us today and support Shining Care.
Okay. And just real quickly, our website is full of very helpful information. So you can refer people to our website. We have articles, links to really helpful websites and any events that we're having, it's on there. So that's shiningcare.org. And then just real quickly, are some upcoming events. Again, we're so excited to be able to bring these events into the Bernie area. We do have a virtual symposium coming up. You can see there's really great topics. It's all free. It will be recorded, so if you can't attend from 9 to 3 on the 7th, you can go to our website and find it to watch at your convenience. And then we're getting ready to do a lunch and learn up in Bernie. Can you advance that slide?
Yeah, hang on, there you go.
Cooperating with you. It looks like it's not going to be at Geppetto's Pizza. It looks like we're going to be able to, I forget the name of the church. We just met with the pastor today. The community church up there over by the casino. So it's free. There is free lunch. So
That's Henry.
oh, okay. Yeah. Yeah. So we'll be talking about, these topics. And then we have our upcoming Shining Affair. So if you want an excuse to come down into Reading and have a good time, it's the weekend near Valentine's Day. It's going to be, this was pre-COVID, so we didn't have a 2021, but we're really hoping to have one this in 2022. We have just a super fun time. So we invite you to join us. And this is our main fundraiser for the year. So this helps us, this really helps to fund those assessments, the care planning, care coordination that we do.
The training.
Pardon?
I said, and then our training, our
Yes.
educational training. So our free services are really, a lot of it's done by this fundraising. So I think
more information on that. And then also, we're hoping that Bernie can join in with us. We collaborate closely with the Reading Police Department, of course, Adult Protective Services, the DA's office, Health and Human Services, a lot of different vendors.
RPD.
Reading Police Department. And this year, Reading Fire Department is going to be participating. So we would love to see, and we would love to help coordinate activities up in the Bernie area to raise awareness about elder abuse and ways that we as a community can prevent it, and helping people be aware of, what the different scans are and what they can do as a community to prevent elder abuse prevention. So that's in June. So stay tuned on that and we'll let you know. But I think that you've had the purple flags up there before. Yeah.
Yeah, I think so.
Abe was on.
Huh?
Abe was on.
Well, Abe's an elder.
Well, Abe was on there.
Was he?
He put a chat in there.
Oh, he did? Where is he?
It says, thanks for the information.
Oh, there he is. See, it was one of our guys. He was on the Abe Hathaway's one of our guys. He was at home, so he was watching from home. So that worked out good. So
All right.
what we'd like to do is we want to put your link in contact information on the department's website. So we're going to link that in somehow. Monty and I'll get together and figure out how to make that work. So we're going to create a resource component to our website. So if somebody visits the fire department website just because they're nosy and they see something, then we're going to put your information in there as well.
Awesome. Great.
And I would say that, we can either link when you get the video edited. If we want to link the video, we can certainly do that, because the information that Maggie gave was great information, because we deal with probably 80% of our clients are in that crisis, dementia or delirium, and it's either alcohol induced or sepsis or something else. So we see that on a regular basis. So we'd like to make sure that the video gets put up somewhere, so the folks that did miss it tonight can go back and look at it and get that up and running as well. So
Great.
we appreciate the partnership with you folks, and we'll do whatever we can with our limited staff, right? So
Right.
That's right.
Yes, we can together.
we can small groups can make large things happen, right?
Yes.
True.
And Bob, we have a lot of resources we can tap into. So if, so you need some more training in the future, we have some folks at the county, We have some, we have Maggie, we have Alzheimer's, we have a lot of resources. So you can always just shoot her an email and say, hey, do you have an expertise on this? And we'll gladly see what we can do to help.
Yeah, I know we're doing a lot of APS referrals now. So I'm just brainstorming that anytime we do an APS referral, maybe we should do the referral to you guys as well, so you can
Yeah.
do that.
Definitely, because APS can go in and if, as you know, that if that person says, no, I don't want your help, they close the case and gone. Where if we're involved, we find a way creatively, to get that consent, to get in there. And sometimes, you have to start at the beginning where you're having to build that relationship. But again, we're a dog with a bone and not let go of the bone
Right.
until that client's taken care of, because it's too important. You just shut the door and walk away. It doesn't make the problem go away. It makes it worse for you guys.
So we have a couple of names I think we'll work on and get you phone numbers and addresses and
Right.
get them to you.
All right.
We had one today, a resident that we didn't even know was in the house, quite frankly. We didn't even know. She called because an antenna fell down, and we went and said, where do you live? Right. So we didn't even know it was there, but now we do. But I think she's probably one of those folks that probably would benefit from your services anyway. So.
Okay. And I would say, spread the word of the Gatekeeper program. I think the more eyes and ears we have up there to help prevent, the better, better off you guys are too. And we'll gladly come up, either do Zoom or come up or, whatever we can do to equip the community. I know the chief is going to set up something for us to come and present to Rotary, but as many people we can get in front of to share what we have to help.
Okay, we'll do that.
All right. Well, thank you.
Thanks
It's
for your
been a
time.
very long day for you.
Yeah, it has. It's been a long and traumatic day.
Yeah.
Yeah, it was, like I said, it's just, you have to
Yeah.
work through those things, right? So.
Right.
And if you can get me a list of names and then give me probably to the end of next week, because I have the symposium on Thursday and I'll be editing both. And,
Okay.
and I'll try to get yours done first and get yours to you.
Okay, I'll do that. Yep.
Perfect.
Thanks.
Yep.
Thank
Have a good night.
Good evening. See ya. Bye-bye.
Thanks,
care.
Maggie.
You're welcome. I'll talk to you later, guys. Bye,
Okay.
Bob.
Bye.
Good job. All right. Good night.
Hang on.
Oh,
Stop
yes.
recording.
Stop. I can stop it.